I'm Jane Glassy, for those of you who don't know me. Today we're going to do a SENCo briefing around self-help skills. So we've got a couple of people, 3 people coming in to talk to us. We've got Marie, who's from OT. Tell me if I'm wrong about any of these people. Is going to start us off. Then we have Leanne, who's coming as one of the special needs dentists. I don't know if that's your official title. You can give us a more official title than that in a moment. And then we've got Sarah from our team, who's going to do some support around toileting and SEN and toileting. The reason we've put this one on today, we thought it was really topical with the new guidance coming in from the government about teeth cleaning, and we thought so that really helped us focus us on the idea that we really need to do a little bit around those self-help skills, which is a really, really important part of the early years curriculum. I spend a lot of my time doing things like E8C panel, and they say things to us, of course, well, toileting's got nothing to do with the curriculum, and we have to go, yeah, it has in the early years. So it's remembering that's a really, really important part of that early years curriculum. So, because I haven't got to do lots of talking today, I'm just going to hand over to Marie and say, off you go, if that's all right.
So I'm just trying to get my workshop to load. I am going to hope, so I've been on Teams this morning in this room and the signal is a little bit sketchy. So I'm praying that it is going to be kind while it's my turn to talk. But also just very, very slow because I'm still waiting for it to load up. Sorry, Jane, I had too many windows open, so I closed a few windows, and I think I just managed.
That's okay. We're very well used to. I'll keep talking while you're getting it ready, but we're very used to this. As I said, I was just explaining, I did some training the other day, and the key person that was supposed to do the training came on and went off 4 times, and every time she came on, we couldn't hear her speak. And I was being very calm and relaxed and saying, that's fine, I will deliver your PowerPoint, thinking I don't actually know what's on the PowerPoint. So hopefully yours will work.
It's like loading up part of it, but it gets to the final bit where the actual document loads up and it goes, no.
You've got to love IT. Oh, Sarah's got a hand up. Sarah, are you telling me something?
No, nothing to do with IT. I was just going to say, well, we've got a minute and Marie is just loading up. Don't forget Lizzie's here as well from Speech and Language, Lizzie J.
Oh, sorry, Lizzie.
You might snuck in because I've been letting people in.
I'd like to apologise on that, yes.
Jane, am I right in thinking it's about 15 minutes per go? Because if it is, because this is still won't load up, then why, if someone else wants to go first, then I could go afterwards and it would just mean that I can make sure this is properly running and we're not losing time.
I think you're on mute, Jane.
There you go. Then it wouldn't let me come off mute then for a second. I was going to say, yeah, that makes absolute sense. We'll do that. So I'm going to say, in that case, who has a preference to go next? Is it Leanne or Lizzie? Do you want to go next? Have you got to get off anywhere? Is Lizzie, have you got to get off anywhere, or are you okay?
I'm happy either way. I'm always very busy, so happy to jump in. But if one needs.
I also know Leanne needs to get away, so can I, if you're not desperate to get away, can I ask for her to come next? Sorry, yeah, my cat is trying to join the presentation now. Just as a
okay, I'll just see if I can share my PowerPoint. Oh, I think mine's working.
Perfect.
Can everyone see the PowerPoint? Yeah.
Yep, I can.
Yep, super. Okay, so my name's Leanne Lovell. I'm a dental therapist and I work for Solihull Special Care Dental Services. So I will talk about what we are as a service and what we provide and how you refer into us. And then I'm going to talk briefly about some adaptations to your normal brushing, which you can recommend to parents with children with who have sensory needs that might find toothbrushing too overstimulating, or they don't particularly like the toothpaste. So there's a few ideas here hopefully you can take forward. So I said Solihull Special Care Dental Service is a referral only service, so we can't take everybody sadly, but we can accept referrals from any healthcare professionals, whether that's a doctor, a nurse, We do accept from social services also, or even school nurses and health visitors. We do training with them. And if you feel that a child or even an adult can't go to a mainstream dentist because they do have severe anxiety, extremely complex medical needs, then they can be referred to our service to have a course of treatment. And then obviously we would assess whether we would keep them in long term or whether then we'd then discharge back to their own dentist after the course of treatment had been completed. So it is a further option for parents out there that should they not be able to get their child through the dentist door because they're severely anxious, then we can it'd be an alternative to build up a confidence in the surgery, because we have a little bit more specialised team within our service of specialist care consultants and adult and paediatric as well, and a bit more experience generally. So why do we bother? Why do we need to bother? Obviously, we know that eating, speaking and looks is really important for our teeth, and without them, it's really not that pleasant having no teeth to eat or speak with. But actually there are lots of links now, proven links, that actually improving your oral health has a much positive effect on your general health. So should you have advanced gum disease or poor oral health, you're actually, if you're a lady and you're pregnant, you're more likely to have a premature or an underweight baby. There's a links with dementia now, Alzheimer's. So if you have advanced gum disease for 10 years or more, you're 70% more likely to be diagnosed with Alzheimer's. There are links with poorly more managed diabetes, you're higher risk of cardiovascular diseases such as heart attacks and strokes. You're more common to get respiratory infections, and there are links with cancers and also rheumatoid arthritis, and there are others as well actually, but the list is endless now, and these links are proven. So although you're looking after your teeth and gums should be good enough motivation to look after them, but it's actually what long-term effects it can have on your general health also that we really need to try and improve the oral health and start children at a young age with good habits so they continue throughout life. So just as a little bit of background, in the average decay rate of 5-year-olds in England is 22%. So that's 22% of 5-year-olds have decay in their teeth. Okay, so they're not choosing their brushing regime and they're not choosing their diet at that age. So decay doesn't happen overnight, and dental decay and gum disease is 100% preventable. It's one of the most common diseases in the world, but yet actually it is preventable as well. And the children at 5, the average decay teeth is 3.5 teeth. So it's not just one, there's multiple decay teeth in their mouth. In Solihull, we do fare slightly better than the national average. It's only 15% of 5-year-olds. For me, 15% of 5-year-olds is still too high. But if you actually break that down, though, in Solihull and in the north and south divide, because it's very linked to affluent areas and deprivation, in the north of Solihull, we actually have a decay rate of about 25%, and in the south, it's much less. So our average is 15%, but that's not really a true reflection of our locality within Solihull. And it is just really as well, particularly for this SEN talk, it is a multifactorial disease. It isn't just about these days we look, oh, you've eaten too much sugar. It is looking at a patient's susceptibility and their medical history. It's looking at about their brushing plaque control. Are they using the fluoride preventative measures? Are they do they have their dietary requirements? Are they quite specific with their eating? Have they been to the dentist regularly? So we do try and look at the bigger picture now, because it isn't just about, oh, you eat too much sugar, just stop eating it and going away. So dental decay and gum health, we do look at the bigger picture, particularly with our patients. So the consequences of poor oral health, obviously, we know if anyone's had toothache, it's the worst thing ever. Eating difficulties, having problems sleeping. And if you're not eating and you're not sleeping, we all know how hangry we can get when we're not a little bit irritable. And in children, that can be exacerbated quite a lot. Having missing teeth through decay can affect their speech. And then we've got also increased school absences because they're off going to the dentist, or in pain, or they didn't sleep very well, so the parents are keeping them off. It hurts when they brush, so then they're in a vicious cycle of not brushing, and it can interfere with social activities. So kids can be cruel. If they can find out one little area, a black tooth, and point it out to a child, obviously, you know, and make a point of it, you know, they will. So it can be affect people's confidence as well. So I'm just going to go over brief what we should be doing, and then I'll talk about some adaptations for you. So what we should be using, a manual or electric toothbrush. It doesn't really matter. Children can use electric toothbrushes, but they are advised they should be supervised. Just because if you take the head off, if anyone's got an electric toothbrush, they have got a metal little prong underneath it, which is quite sharp. I always advise all children should never be running around with a toothbrush in their mouth. I have worked at Birmingham's Children's Hospital and seen the x-ray of a child where it's gone through the roof of the palate because they were running and they fell. So no running around with the toothbrushes in the mouth. That's like my biggest thing I always say. So it doesn't matter what you use, as long as you're happy using it. We do recommend, especially for children, we want the small-headed flat trimmed brush. You should be replacing it every 3 months. If the bristles get really splayed before the 3 months, you can replace it before, but a toothbrush should typically last every 3 months. And that's the same for an electric head as well. And if you've got electric, we recommend you keep it fully charged at all times to get the maximum power off the brush. Bear with me, I've just lost my slides. There we go. So toothpaste. Children from the age of 3 should be using 3+ should be using a fluoride toothpaste, and actually they can use an adult's toothpaste. From the age of 3, the strength of the toothpaste is exactly the same as an adult's toothpaste. The children's ones in the shop just tend to be a little bit less minty. And like my children would say, oh, it's too spicy, you know, at the age of 5 or 4. So I still bought them the children ones. But as long as it's 3+, it actually contains the same fluoride as an adult toothpaste. There are additional toothpaste you can get on prescription, but these are for the older children that are very high susceptible to decay, and that's for 12+ and a 16+. There's different strengths of fluoride toothpaste, so that is something to bear in mind, that can be prescribed from a dentist or a doctor should anyone going forward be very high risk of dental decay. We should be using a pea-sized amount of toothpaste, and they should be encouraged for 2 minutes twice a day. If the child is under 3, again, they should be using a fluoride toothpaste, but it contains a little bit less fluoride. Children aren't as good at spitting out toothpaste under the age of 3, so hence there's a little bit less fluoride in there. So you'd be using a smear of fluoride, okay, again, because they're not the greatest at spitting out. So 3+, it's a pea size. Under 3, it's a smear and a children's toothpaste. And again, encouraging for 2 minutes, but you know, our children trying to get under 3-year-old to brush for 30 seconds sometimes can be an accomplishment. So anything is better than nothing. But the biggest take home as well is when you finish brushing, this is for all of you as well, make sure you spit that toothpaste out, but do not rinse it out with water or mouthwashes. Toothpaste has always been designed to use like this, but lots of adverts from years ago show people rinsing with mouthwashes and water, and it was never designed to be used like that. You should be brushing your teeth, spitting out the toothpaste, leaving almost like a reservoir of the fluoride toothpaste on the teeth, and it will protect them for longer. So changing, not everyone will tolerate a minty toothpaste. We always encourage to start off on a minty one where possible. It's much easier to continue on the minty because the adult ones generally are. However, the supermarkets and the pharmacies have adapted and understood that actually not mint is for everybody. There are a complete range of toothpaste out there now, particularly the one I want to draw your attention to is the one on the top left, the Aura Nurse. So this is a flavour-free and foam-free fluoride toothpaste. So you can get it on Amazon or some like pharmacies like Lloyd's. And it's a really, really good toothbrush. If anybody has really sensory needs that they can't struggle with flavour or sensors in their mouth, it really, really works. And we've had such a success rate of recommending this to parents in the past. So it doesn't foam up like your normal toothpaste, but it does get that fluoride on the teeth, which is what we need to protect them as well. You can try other toothpaste, so there's Aquafresh do a strawberry one, there's lots of bubblegum ones. The ones I want, there's the ones called, I think they're called Nice Smile ones, the 3 coloured ones on the right. They are from Home Bargains, and again, they do watermelon, peachy clean, and feeling great. They are, again, flavoured toothpaste with the correct amount of fluoride in. However, what I want to bring your attention to is, you might have heard about these ones, High Smile, very publicised on Instagram and places like that. They're American. They don't contain the correct amount of fluoride toothpaste in them to protect the teeth. The one in the middle actually contains no fluoride. So we've had like parents come in saying, oh yeah, they're using this High Smile toothpaste, about £9 a tube as well. But actually then they're not receiving the maximum amount of fluoride that's recommended from the guidance. So if I go back to the other slide, as you can see, they look very much like the Nice Smiles. So it is really confusing with parents. So generally, we try and say stick to the brands with the children, and at least they know they're getting the right amount of fluoride on the teeth. So from 3+, it's almost like an adult strength toothpaste, and under 3 is a child's strength. But the Colgate children's toothpastes, they generally tend to be mild or mint anyway. So it is worth looking around. The Colgate one have one that changes colour as well. So this one, the more you brush, it goes blue. So actually you want to then encourage your child to make sure they're brushing really well, and then they'll spit out blue toothpaste and it went in white. And that way, you know, it's just like making it more exciting for the children to brush their teeth, and it isn't just a battle about saying brush your teeth. So what you can get as also is if you are limited with the brushing or having difficult access, there are these specialised brushes out there as well. So the one, the picture on the right hand side is called a Dr. Barman's brush, and the one on the far left is called a Curve Collis brush. And as you can see on the middle picture, it cleans both sides of the teeth at the same time. So if you've got limited opening or limited time in the mouth and you want to clean more aspects of the teeth, because we should be cleaning the outsides, the insides and the tops, it cleans it all in one go for you. So they are brushes that you can consider should you have limited time or resistance from anyone with brushing, that they can clean more areas a bit quicker for you. What we recommend if you're helping anybody brushing their teeth, the worst thing you can do is stand right in front of them and brush them like this. So if you stand in front of someone now and did that, it's quite invasive and you're in their personal space. Standing to the side or behind them, you are brushing like your own teeth, okay? So you're going to have much better dexterity and you're not in their space, okay? So they're more likely to tolerate you helping them. As you can see in that picture, the child's holding the brush, and that is another great tip, is actually let them hold the brush and you guide them. That way they think they're brushing, but actually you're helping them get to the right areas or the areas that need brushing, okay? And again, children find it much more tolerable, or even patients with dementia, we recommend this too as well. So again, making it interesting, we found a lot of children that have autism love to watch themselves when we're doing treatments. So we quite often have the mirror and they hold and they're watching us. It's almost like they have a little bit more control over us, obviously, if they're watching what we're doing, making sure we are doing everything that we've told them we're going to do. Then you can get brushing charts. So there are loads of brushing charts online, which you can download, or even you make your own and make it relevant to their topic that they like. And ticking it off every morning and evening is just like a nice chart you can follow. And at the end of the month, perhaps if they do complete their chart and brush every morning and every evening, you know, there can be a tiny reward at the end. Obviously something that's not sugar, but something at the end that they might like to enjoy. Almost there. Okay, technology is out there these days. There are lots of free brushing apps you can download, and these are contain like 2-minute videos, or they contain like little apps where every time you brush your teeth on the Aquafresh one, you get a free points, and then you can buy outfits for the little toothpaste nerd, or they call him, and you can do things like that and buy hats for him and shoes for him the more often you brush. There's one called Brush DJ, that's a really good one, but older children that have phones is actually encouraging to say, play your favourite song, keep brushing until the music's over, you're distracting them by playing the music, but actually encourages them to be in the bathroom for about 2 minutes, okay? Because most songs are 2 to 3 minutes long. Or even if it's they like watching a certain TV program, if there's adverts in the TV program, most adverts are 2 minutes, 3 minutes long. So keep them brushing, okay, while the adverts are on, and then it encourages the time for brushing. Obviously, you've got little brush timers, you know, egg timers you can get. There is a thing called Brush Link. This is to buy, but we did have some free from the charity actually at University Hospital Birmingham, but we haven't got any more left, sadly. These are really good because they go on the brush, and you download the free app, and it literally tells you where to brush for the 2 minutes. And if you're brushing correctly, you get a green bar at the bottom of the phone. And at the end of the 2 minutes, it gives you a score out of 100 of how well you've been brushing. So the target is then to try and beat that score each time you're brushing. So if they're sort of very competitive or very screen sensitive, they like watching screens, they know that's a really good option as well. Role modeling. So we do encourage, you'd be amazed at how many children, if the parents brush in front of them, it becomes normal to them. So we do encourage it from a really young age. It might mean the parents are brushing their teeth a bit earlier in the evening or as an extra time, but actually children learn from parents, and we do encourage you to role model and you know, brush with them and alongside them to keep them going for the longer brushing. Sometimes getting the brush in the mouth is just the whole battle in itself. So sometimes it is better just to take a step back. You can get some toothbrushing models. You can get laminated sheets. You print off one of these mouths off the internet and laminate it. You can draw some on like some whiteboard pens, some bugs on the teeth, then start getting the children to brush off the bugs initially. Just getting them to hold the brush and realizing that actually, you know, it's not sort of a bad thing. It can be a thing that can really help and clean the teeth. So sometimes taking a step backwards can be good. And also disclosing, you can get little home tablet disclosing dies, showing them visually, you know, that actually this is where the germs are. Now you can see them and off you go, because it is difficult for a child to understand or comprehend actually if they look white, what's the issue? They can't see the germs, then why do I need to brush them? But if disclosing them highlights that a lot more. So we do have an Instagram page as well, should anyone want to follow it. So we do recommend it to parents. It's a University Hospital Birmingham Instagram page. It's called Keep Solihull Smiling, and in each week we do dental posts about how to improve your oral health in tips and tricks of lots of different ways mostly. So you know, it's a great way to follow and look out for correct oral health information, because there is a lot of false information out there as well. They're also, this QR code is a video that's sent to all parents in Solihull primary schools in reception, and it will be nursery also this year. And it's a quick video, about 2 to 3 minutes long, and it's quite an interactive video. It can be watched with parents and children about the 3 key things that you should be doing to help look after your teeth. So again, if they won't listen to the parents, getting them to watch this video might be something, actually, if it's coming from another source, they might take it on board that little bit more. So I'm just going to very quickly just go over diet now. Oh, sorry, go over this. So we want to find the right brush for them. Sometimes giving children an option we find in surgery as well. If we say, right, we're going to brush your teeth now, and they go, no, you're not. But we say, well, shall we brush it with this or shall we brush it with this? And then giving them the choice. So we are going to brush it, but actually, which one are we going to brush it with? They still feel they've got more control in the decision as well. Making it fun, like I said, brushing charts, apps, you know, make it interactive and like I said, be a role model, show them what you should be doing. Keep it positive. Don't be panicked if it's not happening straight away. It takes time and encouragement to build up to a positive attitude to brushing teeth. But it's about sticking with it and, like I said, trying to find what works for them, but trying to keep it as a routine. Do keep trying. So just quickly go over diet, because that is another influencing factor in dental decay especially. This is the way I explain it to parents, okay? Teeth can cope with 4 acid attacks a day, breakfast, lunch, dinner, maybe 1 evening supper meal, okay? If you have a pack of Smarties and you eat 1 Smartie out the pack, that's an acid attack on your teeth. If you eat the whole packet in 10 minutes, that's 1 acid attack on your teeth. So not for your waistline, but for your teeth. Actually, it's not how much you have, it's how often. So if you're going to have recommend sweets or cakes or biscuits for children, what we recommend is you should have it a dessert straight after lunch or straight after dinner, because it's included in that acid attack. And it's in between meals where we need to really try and stick to sugar-free alternatives. So I'll just put a few, out of the alternatives there. People don't think, oh, maybe an egg, that actually is quite a good sugar-free snack. Plain yogurts, not fruity yogurts, a lot of them contain sugar, so just be cautious if you're offering your yogurts as snacks in between meals. And obviously your cheese, your fruit, veg sticks, and plain crackers and plain rice sticks. Sticks. If anybody wants any further reading, I was going to get Jane to send this out afterwards. The British Society of Paediatric Dentistry have done like a really good handout on information for tips and again about brushing for any children with special educational needs. So that's quite a really good read, and would recommend that as well. There are lots of support out there. So yeah, again, that was the Instagram, sort of the link to it. Just before I say any questions, so as Jane said, there's been a big push about trying to improve oral health, particularly in children in schools. So I'm currently working with the council, and we are implementing supervised brushing in schools, and we're targeting 12 schools at the moment, particularly mostly in the north of the borough. This has been proven, if brushing once a day in addition to their home brushing in school over 2 years, actually can significantly reduce the chance of dental decay. So it is coming out there. We have got lots of children with sensory needs in the school, and Fallbridge are quite happy to. I've been working with them actually for they're in their 3rd year of supervised brushing, because we did them as a pilot because we kind of knew this was coming through. And we had children, I'm not going to lie, the first week we had children under the table, we had children running out the room, and I was thinking this is never going to work. But with the adaptations of, the no flavoured toothpaste, we gave them models to practice on first, and then they built up to brushing. By the end of the year, every single child was brushing at lunchtime, after lunch, with all the other children. So it does show with time and the right supporting aids, it can improve. And it is a life skill we're trying to teach these children that hopefully will go on and protect them, their general health, and not just their teeth and gums. Any questions? Sorry, it's a very quick talk.
That was absolutely fabulous. There is one question in the chat. It says, is a referral only allowed for Solihull GP registered children, or is it across authority?
Okay, so the criteria is you have to live in Solihull, or you have to have a GP, or you attend a Solihull school. So if you live on the border, perhaps we have a lot of our work colleagues that live in Coles Hill, which is considered as Warwickshire, but their children attend a Solihull school, they would still be accepted as a referral. In Birmingham, it's called Birmingham Community Healthcare Trust. They have a referral system and clinics within Birmingham as well. So this isn't just Solihull. There is a community dental service within Warwickshire, Birmingham, Solihull. So what happens now, because it's all an internal referral on computers, if it was highlighted that they're not in our area, we would then send it to the correct area, if that would make sense. So if you're not sure, send it in anyway, and it will be bounced to the correct trust.
How very helpful. Because we have lots of problems being like early years and children being across border, so that's a really helpful way of doing it. That you'd bounce.
Well, that's why they've done this IT sort of essential referral, because we were getting some, well, we can't do anything with it, and then obviously they get left, and then they're looking. The parents were thinking, well, I've got a referral, but now they've not accepted it. Where do I send it now? So this helps stops people getting lost in the system a little bit.
That's brilliant, thank you. I'm more than happy to send that. I believe, and somebody on the call might tell me I'm incorrect, but the leaflet that you just highlighted, I think we've put on our SolGrid page. So those of you that
lovely,
use our SolGrid page, it should be there already, hopefully. If not, it's coming very soon. Sarah, was that you coming off mute to tell me?
No, just to say Marie's got a hand up as well. Just somebody's got a hand up for a question.
Sorry, I can't see that at the moment. Go on, Marie, what was your question?
Sorry, yeah, thank you. One, oh gosh, there was so much information there.
Sorry.
I was frantically catch some of it. No, it was all really helpful. The name of the brush, the one where if children won't keep it in their mouth for very long and it will do all directions. What was that called? Or how would I Google and find that?
It's called Dr. Barman's. I'm just trying to find the slide now for you. Here we go. So this one, which I personally find better, is called Dr. Barman's.
Barman, yeah, B-A-R.
And then if you just Google it, it will come up on Amazon. Not, there are other places you can buy, but just to look at it and understand, you can. That's place. And then this one's called a Curve Collis, Collis.
Lovely. And also, like, how do I find out what severity of children will you see? Like, how complex do they need to be to reach your threshold?
They don't actually. We do accept children with it already a high decay. It's already got high decay teeth. So and they don't actually have to have anything on their medical history. But so it's anyone with some reason can't get to their own dentist, so it needs to be stated on the referral why they've not got their own dentist, and not being able to find one is not acceptable. What I will say, actually, if you're looking for a dentist, on that Instagram page as well, every 3-4 months we do an NHS list in Solihull of dental practices that are taking on patients. So again, if some parents are looking for a dentist, get them to follow that page, and every 3-4 months we put new lists of dentists in the areas that are taking on patients. So yeah, you just got to explain on the referral why they can't go to their general practice. Perhaps mum's taken them and they refuse treatment, and you know that they need some treatment, or their parents are concerned about something, then that's something that we would look at and assess them. Like I said, we can't keep everybody on forever, sadly, but we would keep them for a course of treatment, get them dentally fit, then we would look at discharging them or taking them on permanently if we felt that was a bigger need.
If you just final question, if you had somebody who just flatly refused to have their teeth brushed, so more from a day-to-day perspective, just wasn't engaging in the process, would that be okay for a referral?
And was there anything else on their medical history? Talking hypothetically, obviously.
As in probably from a sensory perspective, yes. Just not tolerating anything, probably autistic, that kind of.
Yeah, I mean, I would probably on the referral, if you put investigations for sensory issues and current at the moment, would be something to put on the referral for it more likely to be accepted. If it's just they're refusing to be seen, and has the parent got a specific concern, they're worried about the teeth looking yellow or black or in areas, and then, or I would stress on the referral that parent is looking for advice and prevention and what to do, because they're very concerned.
Thank you.
That's brilliant. How very helpful. I like all the extra questions as well. It really helps us to get those extra questions in. So in that case, I'm going to say thank you very much to you. And Maria, are you up and running?
Hope so. Right. We'll share.
Okay, if Leanne, you stop your sharing, and then
have I stopped sharing is the question.
Same little arrow at the top where you. So I need this. All the little arrow where it said share. If you click that, it should be able to click and then stop sharing. Hopefully.
No, I haven't got that. But normally you have, haven't you?
I'm going to just see if I can just take it from you.
Yeah.
If I just press this.
If not, I'm gonna. Yeah, it's gone.
I think that needed to happen.
Perfect.
Thank you, Jane. So I'm sorry, I just couldn't. I don't know what it was. As soon as people weren't looking at me anymore, it worked. So I think it was just the pressure. My name's Marie Roberts. I am the team lead for Children's Occupational Therapy. What I thought I would do today is focus less on all of the different occupations and more on the sort of approach we take in general, because I thought then that might be more helpful for people to then apply to each child that they were working with. So I am repurposing our home-based motor skills workshop. So this is something that we use with parents who have primary school age children, but it has loads of really helpful information in it. So I'm just going to be picking certain slides out. So don't worry, I am intentionally whizzing past things. And I will just keep my eye on the clock, and hopefully we'll be able to finish on time. So let's find number 6. Now, I feel like, can you just see that very small? No, you can see that and read it.
I can see it fine, and believe me, I'm the person that can't see anything most of the time.
Okay. So we'll start by just making sure that everybody knows what occupational therapy is and what we do. So we are with our core priority is making sure that people are living their best life. Okay, so we're thinking about quality of life, we're thinking about what's meaningful to each individual, and obviously that is different. So it's really important to us as therapists that we really work collaboratively with the families that we work with to make sure that they're setting their focus, their goals, their direction, rather than us telling them what they should be doing. So yeah, we're getting them to live their best life, and we're thinking about home. For us, if as adults, it would be at work, or obviously in sort of childcare settings, things and everything else. And occupation is often misunderstood. It's a horrible, horrible word, because of course occupation is whatever we do throughout the day. So anything that's practical and purposeful that we spend our time doing. So day-to-day tasks, self-care, everything you do in the morning when you get up that gets you out of the house in the morning, the things we have to do, and also what we do because we choose to use our spare time. For children, obviously, everyday things are more directly related to the play, how they learn, their sort of preparation for going to school, eating, toileting, teeth brushing. So I was frantically scribbling down loads of those things that we were just talking about, because definitely that's going to help me to support some of the families that I work with better. So that's very helpful. So yeah, so that is occupational therapy in a nutshell. Now, how do I, oh, here we go. So we tend to focus on two aspects. So we look at motor skills, which is all of our doing activities. So things I mentioned, obviously things in the picture, writing, drawing, gaming, being in the playground, riding a bike, eating, all the things that are important to us. So there are doing activities, there are motor skills, and we also tend to spend quite a lot of time talking about sensory processing. So this is not the sensory processing workshop, so I don't have a slide on it, but you know, sensory processing is our capacity to be able to take information in about our environment and also what's happening to ourselves, make use of that in our brain and react accordingly. So we tend to sort of have the analogy about cups with sensory processing. We all do it. It's a natural part of our survival and our interaction with ourselves, our understanding of ourselves and our environment. But there are many people out there who can find sensory processing more challenging. And so when I'm talking about cups, what I'm saying is there are some people out there that have little cups, and going day to day and experiencing what life has to offer can overflow easily and quickly. So small amount of input and the cup will overflow. And that might be things like being in a supermarket, going to a soft play, you know, loud unexpected noises like sirens or hand dryers or hair dryers or things like that. And there are others of us who have very big cups where it never feels like it's full. You know, that satisfied feeling that you get if you've had your cup of tea and you've missed that last few mouthfuls. You just know you missed it. So they'll sort of maybe go around searching, always searching for more. And so we know that, as I said, we're all different and we all have our different ways of processing sensory information. And more often than not, it doesn't disrupt life. We just recognise that some people don't like woolly jumpers. Some people live in shorts all year round. Other people would not go to a theme park if they were paid to go to a theme park. You know, and it's absolutely fine. It's obviously what we're particularly interested in is the children who it's really disrupting life. So they tend to be the two directions that we focus our intervention in. So motor, how are they getting on with learning new doing skills, and also how are they managing with their sensory processing. I realised I turned my page so I could scribble loads of dentist information. Now I need to go back. So when we are presented with a problem in OT, we tend to look out for barriers and bridges. So this is a phrase we use with parents quite a lot. So what is a barrier to learning that skill, and what is a bridge? And thinking about ourselves and our own learning, we know that everybody learns differently. So we know that Some things help us to do better at things, and some things are a disruption. And we're trying to tune parents or, you know, education staff, when we're talking to education, into identifying what the bridges and the barriers are for that individual child. Because what we know is what is effective for one is not for the other. For instance, again, talking about more an adult learning, there will be some people who can't sit in a silent room and work, and others that, you know, so they need that background noise, they need a radio, a TV, they need something going on in the background to help them to focus. Whereas for other people, anything going on is just taking their concentration away from what they're trying to achieve. So for some, it would be a bridge, it would enable them to be able to do better, and for others, it might be a barrier. So what we want to try and get people to do is we want to think about, let me just roll on a little bit, being a detective. So this is what we say to our families, because as I said, everybody is unique. So we have some general strategies that work for certain common things that we see on a regular basis, but every situation is unique. So we ask education staff, we ask parents, be a detective, sit and watch and see what is happening with that particular thing that you are trying to enable that child to do. So obviously the iceberg analogy is something that's really commonly used in lots of different types of teaching, but what we're saying is what you may see on the surface may be just an indication of everything else that is going on underneath. So stop and watch, listen, ask questions for those that are able to answer. Think about, this is focusing on goals, but I'm not going to worry too much about goal setting in this context because we're short on time. But yeah, watch the activity you're trying to get the child to do and just see what happens, what are the bridges, what are the barriers, how is it going? Now also, another way of framing it is thinking about a model that we use. So we talk about putting on our occupational therapy glasses and saying, think about the environment. The environment is so key. Does the environment support that young person engaging and having a go, or is it acting as a barrier? You know, is there too much going on? Is it too chaotic visually? Have they got the space that they need? Are they able to reach the things that they're trying to interact with? So think about the environment. Is it helping or hindering? Think about the person themselves, and this is huge. If they're not motivated, you can't drag them through life. It's so much harder. It's an uphill battle. So is the young person motivated to want to do the task? Are they actually even looking at what they are doing? Is there any anxiety at play here? Is there any fear? Is there any, you know, how are they doing? Have they actually got the skills to be able to do the task you're asking? Or maybe they just literally don't have the coordination, the dexterity, the capacity to remember the 50 different steps that are required to complete the task. And what is the task that we're asking them to do? Can we break it down? Can we simplify it? So be a detective and sit back and just watch and see. So this is, if someone came through our service, this is what we would be recommending and encouraging our families to do. Next thing is we want to move on to strategies. So as I said, we could be talking about buttons, we could be talking about using a knife and fork or a spoon, we could be talking about being able to get them to stack blocks to make a tower. So we could be, you know, it could be any task that you're asking them. Once you've identified what the barriers are, what the bridges are, and what their ability is within the task, think about using match. So this is an acronym that we find really helpful to think about the strategies that you might be able to consider to support the young person that you're working with. So M stands for modify the task. So can we just make it easier? Does it have to be as it is, or is there a way that we can make it easier? Okay, so can we modify the task? So let's just go in with a helping hand to begin with. A, can we alter our expectations of the task? So lots of tasks require numerous processes. So maybe we might need to think about, is it realistic to expect the young person or the child to be able to do all of the steps? Maybe we just want to start with step number 1, or maybe we start with the final step, number 6. So do we alter our expectations? And it's thinking about that just right challenge. What feels achievable for this young person, this child, rather than sort of always going for, 0 to 60 in a second. T is for teach. So teach strategies. So are there any strategies that will enable them to be able to do the task more successfully? So you might sort of think about that. C, can you change the environment? So often it is the environment that is creating the problem. So is there any changes that you can make to the environment? Can you take the child out of the environment and do it in a different context? We all know when we're learning something new, we need full attention on the task. And trying to get a child to function when there is lots of disruption, lots of barriers within the environment, we're just not enabling them to be successful. So it might be about adjusting where the environment itself and setting things up better. And then the H stands for help by understanding. And I kind of like to say, this is where we get to be those children's cheerleaders. This is us being like, I'm wanting something from you. I want to challenge you. I want you to grow and I want you to learn. So I'm going to put my stuff aside and I'm going to make sure I'm with you on that process. And I think for a lot of parents, where busy households, they will sometimes say, oh, well, I've tried to get them to do this, or I've tried to get them to do that. But in reality, there's so many other things that are demanding of that parent's time. It can be really hard to truly give the opportunity for them and have that support. So for some children as well, they may feel that the just right challenge for them is a tiny step forwards in the process, because they maybe are very overwhelmed about the expectation, anxiety, fear. They won't engage in something that they know they can't do, so they'll refuse to give it a go. So for some, the next step on the ladder is actually tiny, but you need to get them on board with the process, if you see what I mean. For others, they may be very driven by achievement and wanting to be the same as their peers, and they may be much more determined to kind of fly through things. But thinking about yourself and our capacity to support that process is really important as well. So this is one of the strategies we would always use. There's an example in the next slide that just explains how you might do that. So this is for using cutlery. So modify the task, for instance, might be getting them to practice with really soft food. So no steaks, no sausages with tough skins, think soft vegetables, mashed potato, omelette, things like that are really nice and easy to be able to cut through. Alter your expectations. So we might be saying, I don't expect you to eat this entire meal using your knife and fork. I just want you to have a go 3 times. And I'll be really proud of you for doing that. And it's about that, just being realistic about what's possible for that young person. Teaching strategies. So if we're thinking about the right technique for holding our cutlery, we might want to put stickers on the back of the cutlery to show them where to put their fingers. We might want to use language like stab and saw to help them to get the idea about that technique and how they need to improve it. So thinking about if there's anything that we can put in place to help them, to enable them to do it. C, change the environment. So we might need to think about, are they sitting comfortably? Are they sitting at a table, or are they sort of perched on with stuff on their lap? Are their feet balanced and steady? Is the room too noisy? Do we need to focus on maybe a particular meal in the day where things are slightly less chaotic? Also, obviously, last meal of the day, they're a bit more tired. That might not be a great idea. So sometimes people might do it as part of a snack rather than necessarily part of a meal. And then finally, help by understanding. So it might be about just talking your child through. It might be about sitting alongside them and showing them and modelling them how you want to do it, hand over hand. And obviously, we spoke about that in the last talk as well. So just gets you to think about each of those sections to consider what it might be that would be helpful. Now, mindful of time, I think I can give you a couple of just helpful strategies, things that we mentioned. So, but I don't want to take too much time up. So one that often works well is backwards and forwards chaining. So with this, what we're saying is you break the task down into steps and you label them 1 to 4. So on the left-hand side, it's putting on a jumper. And you can see the numbers indicate the process that you need to follow to put on a jumper or anything that's over your head kind of clothing. 1, put the jumper on the head. 2, push the arms through. 3, push the other arm through. 4, pull your top down over your tummy. If you were doing forwards training, what you would do is you would get the child to do step number 1, and you would do 2, 3, and 4. And then when they get really good at 1, then you would encourage them to do 1 and 2, and then so on and so forth, so they're successful. With backwards training, for some activities, it's better if you do it in the reverse. So they do the final component of the task. So they get that sense of achievement because they've completed the task, but you do the first few steps to get them to be able to do the 1 at the end. So they work differently for different children. The one I'm going to jump onto, so there's a few of this, but the one that I think is probably most important is motivation. I think if you do not have a child who is motivated to want to do it, as I said before, you are climbing up a very steep hill, because you are dragging them with you. So, and there are many things in life that children have no desire to want to do. So in which case then you need to bring in rewards and you need to make it worth their while. So offer choice, obviously using rewards as much as possible. And within that, and I would say, and I'm sure you guys are probably experts at this, enabling them to choose their own reward as much as possible is really helpful, because if they want to get it, they're more likely to do it. So just make sure as much as you can that they are motivated by making it fun, and all those things I know that you already do. So what I'm going to just do quickly with this last couple of minutes is I just wanted to show you guys our website, because I've purposefully given you generic strategy and process about how we would go ahead. So we would watch what they were doing and be detective. We would identify bridges and barriers. Then we would use match as a strategy to consider how we're going to make a plan. And then we would use individual strategies, like I've mentioned, the chaining approaches, the forwards and the backwards. Motivation is key. Obviously, you've got all your things that you'll be familiar with, like your visual aids and things like that to help them. Obviously, then it's just about practice, and reanalyzing how it went. Did it go as you planned? Did you actually have the complete wrong plan and it all got thrown out of the window? And do you need to do it all again and look more closely, or maybe reframe what it is you're trying to achieve? So, yeah, so I've been very generic. We do have on our website, and I'll see if I can, if I go here, hang on a minute, I think I have to share again. I will just show you the our website, because that has more specific advice for certain scenarios which people might prefer. So this is our Solihull Children's Community Therapies. Lizzie's service here, speech and language therapy, is also there as well. So I'm sure there's stuff on there that would be helpful for people to be aware. This is us, occupational therapy. And if we go here and we go down to SENCo is probably the best one. I was looking for the resources one, it seems to have disappeared. It's like magic. Click on here, and I'm hoping, sometimes Teams doesn't like you jumping around, but I'm hoping you're still following me here. Here we have some self-care advice sheets. So this has got some really helpful stuff. I think we might be reviewing this, teeth brushing, based on all the lovely information that we've just been given today. But if I open this one up, washing, now, have I lost people, or have I still got people?
No, you're definitely all still here, and there's a hand up as well. So I don't know if they want to ask the question. Well, is it Kerry? Do you need to ask while this is happening, or is it something you?
I'm just showing everybody, kind of, just sometimes the screen doesn't follow, does it? But this is one of our examples. So there was lots of examples on there. If anybody wants a bit more specific sort of information and advice, basically. So I'm going to stop sharing. But yes, happy to answer any questions that people might have.
Honestly, that was absolutely fabulous. I love the generic approach, because it really helpful to apply that to so many different self-help skills. I think, has the hand gone down now? There was hand up a minute ago. I'm sure it was Kerry Drinkwater. Is it not? Kerry, was it you?
It's changed my mind.
Did I? No pressure. If it wasn't you, it may have been that I've seen the wrong person. So maybe you answered the question.
Maybe. Maybe you answered. Clever of me.
Yeah. Anybody else got any other questions? No. That was brilliant. Thank you so much for doing that. I'm really grateful. And as I say, I think it's really helpful way of looking at things. So that was great.
Yeah.
So because of time,
and you can be an OT.
There is a question.
Yay, that's all we need to do to qualify, is it? I'm sure there's a lot more.
There's
Due
a
to
question
time,
Jane,
I'm going to. Oh, there is another question.
in the
Sorry.
chat.
What's the question?
Any tips for children sitting down for meal times, suspected ADHD, sensory needs, but not even 2 years old, so it's very early days?
So I think, so not even 2. I mean, are they out of a high chair? You'd think they might still be in a high chair, mightn't they? I mean, obviously, sitting with an adult is always going to be easier than expecting the child to sit independently. Making meal times quick is really helpful. Yeah, I mean, I would assume that a 2-year-old would still be in a high chair. So I can't imagine that.
Probably not in the nursery setting, because they're all of the age. They would probably still have them in chairs at a table. Or yet saying yes.
They are in a high chair.
No, they're saying yes on a table and very independent and able.
Yeah,
but
and
choosing
sometimes you can be a
sit.
bit creative, can't you, about where you put them? So they're sort of wedged in a little bit in a corner. It's harder for them to actually escape. So maybe a bit of thinking about how you can use your environment to your advantage to be able to sort of block their exit. Obviously making things realistic to them. If they're an eat and go, then I don't think it's realistic. So think about alter your expectations. You might not want to expect them to have to sit and wait for their food to be delivered. And for
I'm
them
so
to
glad you said that, because that's where I was going to go.
Yeah, so it might be about thinking about, actually, if they've put that bum on that seat and ate their food, then well done. You know, if that's what's realistic for them, then maybe we celebrate that success rather than expecting them to sit for everyone else to have finished, or for them to wait for their pudding, or, you know, if it's okay for them to get up and go and then come back for anything extra, then I'd probably, maybe a bit of alter expectations might be a smart idea. Or yeah, thinking about where you sit them in the classroom. I mean, there's wobble cushions and things like that, but for 2, I don't think that would be appropriate. I think they'd probably be, if they had one of that, they'd probably be on the floor. Losing their balance.
Said thank you very much. So you've obviously done. Oh, hang on, I can see another. Oh, it says tender years. That was the next question.
Hi, I'll try and be really quick because I know you're short for time. I appreciate physio sits outside of your department. I appreciate that. And I don't want to be negative, but we've really struggled with physio departments where they've seen children. We've had no reports. We've had to rely on parents' feedback following appointments. And just really, if you get an opportunity in meetings with physio teams, just to send that back, really, that's really frustrating for us as settings where they're children with quite significant needs, because they wouldn't accept them if they weren't. But we haven't always had any feedback from physio, and that's been really, really difficult to sort of work targets and things into a child's plan. And these are children with needs outside of typical and normal development. So just if you
what's your name, and I'll have
Lisa from Tender Years.
Lisa.
I can give you information about a specific case that was really quite challenging.
Can you give me initials? Just first initials.
RW.
RW. That'll be enough. Okay.
Yeah,
All
so
right.
she
I'll
was
pass it on.
About 3.
Yeah. No. I'm sure that will be. Well, I've got no idea, but I'm sure that the physio team will be able to.
She's got ongoing needs, so we would love to have further communications with them.
Okay. No problem.
Yeah, really appreciate it. But yeah, great stuff, Marie.
Thank you. Back. That'd be great.
No problem. I'm going to shoot, because otherwise I'll be late for school pickup. But
you need to go, and I'm conscious that Lizzie J is waiting, so I'm going to pass that on. So thank you very much for coming. Really appreciated.
My pleasure.
Okay, right, Lizzie. So you're up next. I love this when we go through people at this speed. Sorry, everybody. I know this is a lot of information, but bear with us. It's great.
I'll have a go at sharing this. Fingers crossed it works. Hoping you'll be able to see it. Looks like it's loading on my end. Can you see that? Yes, I can see some nods. Perfect. So hello, I'm Lizzie J. I'm one of the specialist speech and language therapists in the dysphagia team. At the moment, I am the only dysphagia trained therapist in Solihull, other than Christina Fletcher, who's in the complex needs team. So in the main community part of the service, it's just just me, whilst my colleague's on maternity leave. So for those of you that haven't met me before, hello. I'm hoping I probably have met most of you or come across most of you before. So for those of you that don't know what dysphagia is, so in speech and language therapy, we've got two sort of branches to our role. So we've got communication support, so speech, language and communication area of need. I am under the umbrella of that team, but don't have any clinical time in communication at the moment because it's just me doing dysphagia. So the other branch of it is dysphagia. So as you can see on the screen, so dysphagia is a medical term for swallowing difficulties. Essentially, the simple way of putting it is when food or drink goes down the wrong way. So if it's going to go into your lungs rather than into your stomach. So just putting this sort of small diagram on here so you can see sort of where the larynx is, which is where your throat is. And that's the main bit that I think about when we're watching children eat and drink and when we're assessing the safety of their swallow, obviously combined with their chew and their tongue and all of those kind of things. But the main bits down there in the larynx is where we identify if it's going down the right way into the stomach and down the esophagus, or down into the trachea and into the lungs, which is what we obviously wouldn't want to happen. Speech and language therapists are recognised by the Healthcare Professions Council as the specialist in eating, drinking and swallowing. So despite sort of other professionals might having roles or as part of that assessment, including like paediatricians or consultants, our role is that assessment. So there's obviously we're based in the hospitals and out in the community, working with both children and adults. Obviously my specialism's with children. So when we don't manage a child's dysphagia, there can be a quite high risk of all of these things on the screen. So I'll go into what aspiration is in a minute. It's on my next slide. But obviously there's risk of respiratory infections, so chest infections, choking, death, dehydration, poor health generally. Obviously, there's a lot of anxiety related to eating and drinking, which I'm sure you will have come across with your families that you work with. And ultimately, my job is to keep those children healthy and at risk, trying to reduce all these risks and essentially keeping them out of hospitals, keeping them at home. So the main thing that I am looking out for my assessments of children eating and drinking are signs of aspiration. So these are the signs that things are going down the wrong way. So if they're going down into the lungs or sort of might enter the airways and popping back out. So things include change of facial colour. So obviously going red, hopefully not going blue, but that obviously is a risk of that aspiration. It notes on here gagging or frequent coughing. Gagging is quite a normal part of the eating and drinking process, but we can have some children who will have a slight gag that will then lead into that proper coughing. The difference between a slight sort of throat clear and a big aspiration cough is quite noticeable. So you'll probably think about the times that if you've drank really quickly and it has gone down the wrong way, you can feel it sat on your vocal folds there. So you're coughing for a long time and you can't stop that cough. That's that cough, that real aspiration cough, compared to a little bit of a cough isn't what I would be worried about, is that sort of higher level cough. Eye tearing, breathing changes after eating and drinking, consistent refusal of food and drink, and then gurgly cry or voice after eating or drinking. So they're the main areas of aspiration that we look out for. So their essential criteria is so children need to have risk of those, and we've observed those behaviours.
Oh dear. Lizzie seems to have frozen. Lizzie, are you aware you've frozen? Not at the moment. I'm going to give her a few minutes because sometimes it just clicks back in. Sometimes she might be frantically at the other end, trying to come back in. Ah, no, are you back, Lizzie?
Sorry.
There you are. That's okay. You froze for a little bit, but I'll let you get on.
The joys of working from home. It just said it was reconnecting. I thought, it's typical when I've started to talk, isn't it? Yeah, so they're the main areas of aspiration. I will go into sort of referral information later on through my slides, so to give you a bit more information how to access the service and things like that if you're not 100% sure. If you've ever received one of my reports or information about dysphagia relating to a child that you work with, you'll notice the IDSI levels on the reports. It might be on the assessment or on my recommendations that I've given for children. So they're standardised levels for the whole world. So there used to be, so when I was doing my training way back when, there was different levels used in different places. So it's a bit of a nightmare if you go on holiday and you go away with your report and you know what levels that they fit into. And if families end up in hospital, then actually the communication between professionals, particularly if there's different languages being spoken, is a bit of a nightmare. So in the last couple of years, it's been changed over to the IDSI levels. So these are what we use consistently for all children. So obviously the triangle on the right hand side is for drinks, and it goes straight through to the food side of things. Obviously there is a crossover. So to fit into the level 0, it would be water, so those thin fluids, water, diluted squash, things like that. When we get into the point of that crossover between the green bit where it says pureed and extremely thick, that's your yogurt. So if you think of that, just your normal yogurts, obviously yogurts can vary in consistency, so they could be that liquidized level, so varying between those levels. As we go through the foods, things become a little bit more specific. So minced and moist is like your mashed diet. So if you think about mashed potato, it's that kind of consistency. And then soft and bite-sized is again very specific. So it's not just small bits of food. The size to fit into this category is 8mm by 8mm, so very, very tiny. Essentially the size of a pea, if you sort of have that in your mind. So that's sort of that, and then obviously everything else would fit into that regular category. I wouldn't be expecting you to identify what would fit into each category. Obviously that's my job to do, but just so you have a bit of an idea and understanding of when I'm talking about those IDSI levels, what they are. We can obviously have food that changes when you're eating it. So thinking about what sits, the crisps, obviously when you put them in your mouth, they melt. So there's that category down the side of that transitional foods. So what sits, ice cream, jelly, chocolate, all those kind of things fit into that transitional, because when you put them in your mouth, they change in consistency. And if we're thinking about a child who's not safe to have thin fluids, that are they going to be safe if they've got something that can melt down into that thin liquid like a jelly can, for example. So obviously the consistency of foods is what we look at a lot. So moving on to positioning, so that'll be sort of the first generally part of my assessment that I would be looking at. So most children that we work with, we'd want them to be sat upright, in an upright position, with their head in that midline, with a slight chin tuck. So we categorise the chin tuck because obviously it's a normal position for us to be sat in this kind of position anyway. Some children will have their heads tilted up and down or to the side, so trying to make sure that we're in that midline with the chin tuck to try and keep them in that lovely position, to make sure that their airways aren't open. So if we have our head tilted back, our airways naturally open, so obviously they're at higher risk of aspiration. And obviously if your head's on your chin, it's really quite hard to swallow, so trying to make everything easy and as safe as possible. Depending on when you're working with the children, so obviously I work with children right from birth through to 19 years of age, so obviously these recommendations can change, so depending on the level of disability, if they're in specialist seating. We work very closely with occupational therapy, with physiotherapy, to make sure we're providing the right recommendations, and that they've got them in the position that we'd want them in for safe eating and drinking. But obviously are working with the tiny babies as well, so those recommendations can alter. Likelihood you're not going to have them that tiny, but obviously just so you've got a heads up, you think, oh, well, Lizzie said they'd always be up in this upright position, and obviously they can alter if they're smaller, really. So yeah, so they're the main two parts of the service. So thinking about positioning and thinking about texture modification, really. The next bit I wanted to talk about, which probably will fall into the most important part for you guys, and these children are what I would call my sensory based feeding difficulty children. They are, for me, lower priority because they are at less risk of aspiration. So the higher risk of aspiration, they're a higher priority for me. So they're more at risk of choking and dying. Whereas these children are the ones that are less likely to want to, sorry, I can see all the little message popping up, just trying not to distract myself. Yeah, so these are the children that are less likely to want to eat. So our aim really is to always make sure that meal times are positive. So I've just listed sort of a few things here about making them enjoyable and positive reinforcement and all those kind of things to think about while we're supporting children's meal times. So making sure that they're enjoyable. So that real careful balance. You know, some children find it really difficult to sit down at the dinner table. They might always have had telly on at home or music on, or have been doing something to keep them distracted during meal times. When they're in nursery, it might be very, very different. So trying to have that positive reinforcement to keep them to sit and attend to that activity. So same as anything, sort of with my speech and language therapy head on, that you know, we can't force children to sit down if they don't want to. And what you don't want it to become is that real battle, because if they're not enjoying their meal time and then we're forcing them to sit down and we're holding them there and trying to, you know, and they're all upset and it's all just a bit of a mess. So trying to make sure that it's positive and sociable, in a location that is safe and comfortable to them. So even if they're not sat with everyone else, that is okay. If they prefer to be sat with everyone else, that's okay as well. They might want a quieter meal time. It does need to be that sort of relaxed time to make sure that they're not getting distressed. Oral aversions is mentioned on here. So the children can be at risk of oral aversions for any reason. So they might have had intervention as a baby, so they might have been born early and had NG tubes or oxygen or CPAPs. You know, there's lots going on that could have impacted them. Again, continued throughout life, they could have still had intervention on their face. And it can cause that oral aversion, even if that's really early on in their life, then that can impact them later on in life. Obviously, if there's developmental concerns, if we're thinking that children might have autism or sensory needs overall, that can impact what's happening in their mouth. It's really, really difficult because we can't obviously force children to eat. It's all about that positive enjoyment and that positive experience for them. So that brings me over to thinking about the steps to eating. So obviously, there's all these different steps to go through to children to then eat food. There is actually 37 steps to eating that we have to go through. So we might go through that in a couple of seconds. We might look at that food, smell it, taste it, eat it, like it, and that's great. Some children have to work through each and every step to be able to get to the point of then enjoying that food, or enjoying that experience of that food. So an example of that might be that having it in the same room as them might be really distressing, and actually their behaviour changes because they can smell a food in the room, or just the whole experience of seeing a food. So then working through those steps to then interact with that food is how we would overcome that. Essentially, the way to do that is what I would call messy food play. So working through those 37 steps to eating for each food. Some children might need that from sort of working through the textures as well. So we might need to start off with dry foods to then build up to the sort of slightly wet, and then those really wet foods like soups and things might be too far for some children to start off with. So you might have to start off with those drier foods. When we've seen children for eating and drinking difficulties for sensory-based needs, we provide them with quite a bit of advice and leaflets through the post to work through these steps to eating. So in those, there's a messy food play booklet with just ideas of different messy food play activities that they can have a go at. Because the advice and support that we offer is obviously quite limited, being an assessment and advice service only for dysphagia. So trying to give them as much information as possible to support them. So the one thing to sort of revisit, I guess, at this point is sort of who is then referred to us. So there's obviously lots of children that would be sort of put into that category of fussy eaters, but they don't always need dysphagia support. So we go back to those signs of aspiration, and if we're seeing those signs of aspiration in collaboration with that difficulty eating, that fussiness and that sensory based need, that's when we would be involved. But obviously there's lots of children out there that they're very in need, so I'm always welcome any questions. Most people have my email address and can get in touch all the time, and I'd rather you ask the question, would this child fit into your criteria, than not be not sure. When each child is seen, they'll have either a report or a mealtime plan, which will include the information about their positioning, their eating, their drinking, and any sort of emergency information that is needed. So who to go to in those times of emergency. So I talked about referral information. So same as speech and language therapy overall. So for the dysphagia team, we accept referrals from essentially anyone involved in the child's care. So any parent, any professional that can give us enough information about their eating and drinking. The referral form is separate to the speech and language therapy one. So it says dysphagia referrals only. It is on the website. So it needs to be on that form, and we won't accept it if it's on the main speech and language therapy form. You'll probably be pleased anyway, because it's a lot shorter than the main speech and language therapy one. It's only a couple of pages, so it's always nice to complete that one in comparison. So obviously if they're accepted, then they'll be assessed by a speech and language therapist. We have also put the link there to the referral form for you. We have a prioritisation system, obviously, particularly because it's only me at the moment trying to manage and juggle my time. So the quickest we'll see children if they're at real high risk of aspiration is 10 working days, and the longest they'd wait is 3 months. So it's not that long for the dysphagia test, or around 3 months. Give me a little bit of flexibility, but roughly around that sort of time. So whilst waiting support, obviously, we're not an emergency service, so in the event of emergency, obviously call in 999. If they're not open to our service, accessing support from the GP for support with their eating and drinking, the GP was likely to refer to us anyway, but whilst we're waiting for support, it's important to note that once they have had their advice from the dysphagia team, they might not be following sort of developmental milestones. So an example may be of, with they're this age, we need to get them off their teated bottle. Yes, absolutely, developmentally that might be appropriate, but in terms of keeping this sort of swallow safe, it might be that they've got different recommendations for us. So it's just being aware of that if we're giving advice to families, that actually if they've been known to dysphagia, we might have said something slightly different to keep them safe. Same information, but I've just popped on here, obviously, if they're open to us and need support, that we can be contacted. Our email address has changed and I've not updated it on there, but I can update that before I send the slides out. Just ends in the uhb.nhs.uk, like all of our other ones does, rather than the NHS net one. And obviously you can come to us for any support, so it doesn't have to be parents. If you're noticing things at nursery or when you're going into settings that you're a bit worried about or want to ask a question, then that's absolutely fine. So as I said, it's just me, so I'm around Monday to Friday. I've put our shared email, which I have updated on this one, and my email address that you can get in contact with. Our service number is there as well, although it is just an answer phone, so I think sometimes it's easier just to send an email to save having to leave a message. And I know it's a bit of a whistle-stop tour, and it is sort of much more medical than other parts of sort of the talks today and sort of the main speech and language therapy service. But essentially, sort of the view is, if we've got concerns about the eating and drinking, I'd rather you ask those questions and just query things if you're not sure if referrals will be accepted. But obviously looking out for that, so those signs of aspiration, and if they're happening for children, then obviously popping that referral in for us to see them. Any questions? I know I've really thrown information at you there.
Yeah, again, thank you so much for that. That was absolutely brilliant again. I think it's one of those services that we talk about but I don't think people always knows there.
Mhm.
So I think it's really, really useful to, you know, to again remind people we are here. It's a service that is great. It's nice. Everybody is always pleased when you say the waiting list is shorter, or next to nothing, you know. But it's also something that I know I go into settings and parents get very, very anxious about. It's one of those things that parents, and often it's parents then struggle to support that development with the eating and the drinking. And one of the things I think is really important, I know some of my nurses are brilliant at it, but often what we do in nurseries, we give them the bottle to drink from, and we give them finger food because actually it's more difficult to do that work. But it is really important that we keep moving them on. I love that the last one talked about eating with cutlery, because you know it's so important. But those skills, those moving the children on to the next level of food. And if we have a problem, if we do get problems with swallowing, there is a service there that can help you. Because I know sometimes parents don't like to move children on from something, do they? Because they're worried.
Yeah, and sometimes you do just need us for a little bit of support as well. I think if you're having those challenging conversations with families, that sometimes having another voice and, you know, saying that I'm the specialist in eating and drinking is that support and that sort of trust sometimes that's needed. And I think that's important, because if families are stuck, it's about you know, supporting them to understand how to support that progression in a safe way, obviously. And particularly those anxieties will be there if they've had early intervention and they've been poorly as little ones, that, you know, it's understandable why that's there. So if I can make anything easier, even if it's having conversations with parents over the phone, if it's not referrals, that I'm always around. I'd love to have loads of time, but like I said, it's only me, but I'll always do my best to get back to people as soon as possible. So, you know, I'd rather queries be coming in so then I can offer that advice and support. And we are thinking sort of long term, what else can we do to support sort of educating parents and everyone out there? Obviously I'm very limited while it's just me and managing stuff, but when we've got a larger team back and when my colleague's back from maternity leave, you know, where there might be more, you know, scope to offer more support for families. But for now we're limited, but at least there isn't a massive long way. That's always a positive.
It's a real positive, and I've always found you very, very quick at getting back to us, so that's great. Really conscious of everybody's time, so I'm going to say thank you one more time, and then say, Sarah, do you mind coming and doing the last little bit for us? Last but definitely not least.
Right there, I'm off mute now. Let me just see whether I can share my screen. Hang on, let me just get this on and then I'll introduce myself properly. Right, now then, let's just do that from the beginning. Right, is that sharing from the beginning? It is not there. Hang on. Let me just, where is it?
It has got the first slide on.
I know, it's not actually, it's not actually on the thing.
Yeah.
I know. Sorry.
Go right to the end. It says from the beginning. If that's normally where you can do it, and then it's
yeah. No, I pressed that already, but that's it. It's on. Thank you. Yes.
Sorry.
I got it on.
Off you go.
Hello, I'm Sarah Phelan. I'm an inclusion support practitioner, and so I'm talking very quickly about learning to use the toilet today. So I've started off with a load of resources because, oh no, hang on, that's just jumped in. Hang on, I didn't want that. Right, I might just lose my up there. So the main website that I'm going to talk about a lot and refer everybody to is the ERIC website, because there's absolutely loads of information there on potty training generally, on specific support for children with additional needs, and for specific support that children might need further down the line. So that's the main one, but these other ones are all also really useful. The help for early years providers, most of that information is taken from ERIC, so that tends to be the one that everybody refers to. So I'm mainly talking from ERIC, and then what I want to really do is focus on the skills that that children need to learn during learning to use the toilet. And so the approach that Eric have is that toilet training is a process, not an event. And that's very much a change from how things used to be, that idea of, oh, it's a sunny day, we're going to take the child nappy off and put them in the garden, and then it's going to be sorted. And this is not that approach. So it's about learning a set of skills, and it doesn't depend on the age of the child, and we're not looking for signs of readiness. So the suggestion is that when a child is able to sit up, then they're actually able to start sitting on a potty, which doesn't mean that they need to stop using a nappy at that point, but that's the point at which you can start thinking about starting to learn those skills. And just as a general rule for everybody, it's better for a child's bladder and bowel health if a child's stopping nappies between 18 and 30 months, so quite a long way before 3, and that's for that is for all children. So it's about building up those skills, not doing it all in one go, but starting maybe earlier than is the norm now, I think, because it has got a bit later because of nappies and the way that nappies are very effective. Right, let's move on. Okay, so when are children ready for potty training? So Help for Early Years providers suggest that most children are ready from between 18 months to 2 years, and the same thing, that starting after 2.5 or 3 years can make it harder to learn the skills. And some information here from Bladder and Bowel UK, just saying how difficult it is for children who don't start learning those skills earlier. So for typically developing children, many will start nursery wearing a nappy, but actually they'll quickly look around and start using the toilet. And although it's hard for the staff, they will actually pick it up and become toilet trained. But for children with learning and processing difficulties, that lack of the practice with those skills means that actually it's much harder for them to catch up, and they're not going to appear ready to do it, but they can still learn those skills. Okay, so the Eric potty training program is called Let's Go Potty, and they split it into 3 sections, which is preparation, practice, and stopping using nappies. And stopping using nappies is basically that bit is the old style, taking the nappy off and off you go. So it's the bit beforehand, the preparation and the practice, which might be many months. That's the bit that we're going to focus on today. So preparation is really, it's the adults doing the preparation. Really, practice is the child practicing those skills. And just to talk about sensory needs, which Marie also talked about a lot. So there's quite a lot of crossover between what she was saying and what I'm saying as well. So thinking about a child's particular sensory needs. So if we think about touch, for some children, the toilet seat's going to feel unfamiliar. They're used to wearing a nappy, that feels safe. For other children, actually, they really don't like wearing a nappy, and it's working out for each individual child what's going to work for them and what they're finding difficult. So again, I suppose the bridges and the barriers. So the sensory experience of going in the toilet, what that's like, and how you can support a child with their individual needs. So the lights, the sounds, the proprioception, so the challenges that they might have with getting dressed and undressed, interoception. So for some children, it will be hard for them to recognise that they need to go to the toilet, and what can we do about it's just having an awareness really for each child. So this one, adapting the environment, how what can we do to make that space that we've got more accessible for the children that need to use it? So thinking about that, what adjustments can we make? You know, have we got fresh air that we can, so that there aren't strong smells in there? Maybe if it's a noisy space with hand dryers and things, just using bath mats can help dampen the sounds. Feeling secure, having the right stuff. So obviously in nurseries you've usually got little toilets and steps so that the child is secure, but maybe just having a rolled up towel, something like that, just to make the child feel a bit more secure on the toilet. What is their interest or motivator? So this comes down to play. How can we use what they're interested in to support them? So it might be, you know, if they're interested in cars or trains, you know, taking the toilet train, making it fun, getting into the toilet, something like that. Or it might be having songs. There's lots of opportunities for songs in this process, I think. So going back to step 1, preparation. So these are the things that as adults we need to be making sure that we're doing. Offering lots of water-based drinks, checking for constipation. This is a really big one, that lots of children can be constipated, and it will impact on their ability to learn to use the toilet. So basically the advice is, if you think that they may be constipated, it's much better to treat that than leave it untreated. And also it can be a bit of a vicious cycle, in that if children start holding on to their poo, then that's going to make them constipated. So just before you get into it, it is just worth getting that treated. So a big one, which might be to do with changing the routines that you have, or thinking about your nappy changing routines, is if you can move towards changing nappies standing up and involving the child in cleaning up and flushing the poo down the toilet, then all of that is building their skills. So it's about the skills that the children need, and it might not be the most efficient way for the staff to do nappy changing, but it is going to be much more beneficial in helping the children to learn to use the toilet. Offering regular nappy off time as part of that nappy changing process, and offering books and toys and songs to support toilet training. And then the next stage is practice. So having regular opportunities to sit on the potty, so that it becomes part of the daily rhythms, really. So after they wake up, after meal times, and whenever you think they're kind of having a jiggle, talking positively about wee and poo, and learning through play. So advanced skills, learning the words and signals to communicate their needs. For some of our children, they're not going to have those skills, but they can still use the earlier skills. So we can use visuals, helping them to understand how to get their pants up and down, and using those routines for personal hygiene. So I think the next one is going to be, so what does it actually look like in our setting? So the suggestion is use pull-ups, so because it's the same action as pulling pants up and down, and then supporting the child to remove their own shoes or trousers, so that they're starting with those skills. Changing the nappy with the child standing up in the toilet area or the cubicle. This obviously depends on the space that you've got and what works, but it supports the child to become familiar with a new environment and a new routine. When the nappy is off, encourage a potty or a toilet sit, and then again supporting the child to help themselves get dressed. It's much easier for the child to take their clothes off than it is to put them back on again. So you might build up those skills gradually. Flushing the toilet, some children that's going to be noisy for them, so they might need a countdown, or to be a bit further away from that when it happens, or just have a bit of a awareness that it's coming. And then working on those washing hands skills. So how will we do it? Regular toilet attempts, like I've just talked about that really, and then using things to support with communication, so symbols or objects of reference or songs. Some children, this is about conversation with parents really, whether potty or toilet. Obviously, again, because lots of settings will have small toilets, they might not need a potty. If a child actually feels comfortable on a potty at home, then it's a good idea to have that consistency. Let's move on. Okay, so just a reminder about using visuals really, that is going to help our children to learn the process that they're going through. And then there's a couple of songs here which I'm not going to sing to you, but this one, if I just do the link, yeah, it's on CBeebies. It's the guy from Gobblebox, and he's singing a song to his baby. It's actually it's Three Blind Mice. There's a and when I was thinking about it, actually you could change it. This is a nappy changing one, but you could change it quite nicely to being about sitting on the potty, and maybe do a count as well. So just wanted to show you that, because if you leave with a song about wee and poo from today, then I'm happy. Let's just shut that one down. There we go. So this again is what Marie was talking about. So this skill of pulling your pants on. So backwards chaining, because it builds in success. So again, it's easier for children to pull their pants down, but learning to pull them back on again, the first step would be that you've done everything apart from they've just got to just be pulled up the last bit of the child's bottom, and then moving on from there, so that they're pulling them all the way up and actually getting their feet into them. So Marie's already talked about that. So step 3, stop using nappies. I'm not actually going to talk about this, because I think this is a bit that everybody already knows quite a lot about. But let me just go on a little bit more now. Problems, poo and wee problems. So one of the really common ones is about children that only want to poo in a nappy, and what do we do about that? And the advice from Eric is actually it's really important that you just give a child a nappy to do a poo in when you know that that's what's needed, because otherwise they're going to hold on to their poo, they're going to get constipated, it's going to hurt, it ends up getting more difficult. But also, if whatever the problem is, just having a think about sort of being a detective again, thinking about what do we think the problem is, and then so returning to that practicing stage. What do they need more practice with? Are they worried about the toilet? Is it the flush? Is it the sense of the things falling down the toilet? Well, there's lots of things that children worry about with this, and just really to say I've chosen that as an example. There are loads of things, and Eric does have a huge amount of information for lots of different issues. So they've got specific advice on that issue, but they've also got specific advice on autistic children who are constipated and how you can approach that. There's specific advice for children who might be smearing poo. So there's a lot of, actually, if you've got a particular issue, it's really worth just having a look and seeing the support that they have available, really. And they've also got a helpline. They've got there's lots of stuff written down, but they've also got little podcasts and stuff. So whatever format works for you, there is something there. Okay, now I wondered if anybody had any helpful hints that they would like to share with each other about this, because it is really nice to know other people's routines and what's worked for other settings. So and before I do, I'm just going to go on to the next slide before I then come out and ask you all that. Some resources for parents, these Brighter Beginnings workshops, which are for parents. Some of those are about potty training and other things as well. And there's videos there. There are Brighter Beginnings workshops for for staff as well, but they are paid for, whereas the parenting ones are free for parents, but you have got to have young children to access them. Okay, right, I'm going to stop sharing that and then ask if anybody has got any hints about this that they would like to share with us, or any questions, I guess.
If no one else has got one for the minute while you're thinking about it, I'm going to come back to your nappy one. So I've worked with children, lots of children in the past, that are really, really anxious. If you think about it, if they've stayed in nappies longer than you would expect, then that removing the nappy and expecting them to poo in the toilet is quite difficult. And very much the poo dropping into the toilet, possible splashes, noises, smells, can be quite difficult for the children. So I worked with a young child who, what we did is initially we lay the nappy across the toilet, they sat on it, they were happy with that. Yeah. Then we reduced the size of the nappy that was sitting on the toilet. Then we had a nappy that was on the toilet that had a hole in it. I mean, the stages you can do these things, and it's called thinking outside the box. But it's really, again, as Sarah just said, it's that being a detective about why, what is it, what's the bit of it that's scary. So when we say give them a nappy, I'm not saying initially you might not put a nappy back on them and let them if they're saying that that's what they need. But there's ways as well of then slowly reducing that gradual removal of and that particular child. It did take a little while, but obviously worked really well. Anybody else got any at the moment? And I'm really aware, Sarah, that some people don't like to speak when we're recording. I don't blame them, because I hate watching the recording back. I hate hearing myself sounding like Hartley Hare. Those of you that are old enough to remember Hartley Hare. So if you've got any other questions and you want to ask, sorry, did someone speak then?
Yeah, I don't care about being recorded, Jane.
Good.
Just to echo what you were saying, I've been running 10 years, 18 years now, and we have had an increasingly large number of children that they're not just small issues, they are complex and significant issues with pooing on the toilet, and that is becoming increasingly significant amongst our sort of children. And we had I mean, I consider myself very experienced, but we had a child that really challenged us last year, and just to say, Eric were fantastic. They worked with us and the parents. We were at a total loss, you know, typical holding, constipation, cramping, developed into an anxiety about being at nursery. Do we go back to a nappy? Is that going backwards? You know, and both us and parents really didn't know what was the right way to go. And Eric were really, really supportive and really helpful along that process of just giving us different strategies, suggestions. And I think I echo what Jane says. We did go back to using a nappy, and I think as practitioners we need to get it out of our head that that's a problem going back, because this child was just holding, and we had to revert back to him using a nappy to poo in, but we were then able to do what Jane described, and it took us 8 months, you know, but this young boy was able to do poos on the toilet before he hit a reception class, so we were pretty chuffed with that. But yeah, the children are having really, really big, significant issues with this. And the only thing to add to it is we found a toy poo that they squeeze, and it's fabulous, because sometimes they become so distracted by squeezing the poo, they forget and let their poo out while they're on the toilet. So I would highly recommend, I don't know if it came off the Eric website, one of the parents brought it in for us, but we use that quite a lot now, and it's really, really popular, and the children love it, even if when they haven't got issues. But I think for some of those children, it just helps them to relax and focus on something other than their bowel movement. So yeah, we've had to do an awful lot of work on that. It's stretched the most experienced of us over the last 18 months, I'd say.
That's absolutely fabulous. The distraction and the ensuring the child is relaxed and calm, that is that prep bit. If you, right from the beginning, you can get children relaxed and calm in a toileting area, on a toilet. I've had lots of children scared of falling down the toilet, all those sorts of anxiety. I am going to reiterate, and there is lots of evidence around this, so Sarah, thank you, but there is lots of evidence around this that we are starting toileting later and later. And one of the reasons people think this is happening is if you were having to wash terry towel in nappies you want your child out of a nappy as soon as humanly possible, because it is a lot of work. If you've got these really ultra brilliant modern nappies that aren't causing you any problem, it is much easier to leave the child in a nappy till longer. So we are unfortunately having much later toileting, and a lot of the anxieties around toileting is because we're doing it later. So more you can do to encourage all of your parents to toilet train earlier. And it's not, I love, Sarah, you saying it's not about looking for signs that they're ready. It's almost, by that point, it's too late. It's start early. And I don't mean, like you say, stage 3, whip the nappy off, but you've got to start with all of those sitting on potties. I mean, actually just spending time in toileting areas, the self-help skills, the understanding that poo goes down the toilet, you know, that helping with dropping the poo down the toilet rather than wrapping it all up neatly and putting it away.
Yeah, we have things strategies. Like magazines and comics and things that are only in the toilet. Yeah. So we actually have a queue of children that want to sit on the potty so they can look at them. So, you know, yeah, massively.
Songs
motivating
that you only sing
children
in the toilet, or music.
Yeah.
I've even been into a setting that had a really lovely little projector in the toilet that had like all sort of things projected onto the ceiling that turned it into a little bit of like a sensory room. That was a lovely one for one of my kids that needed that to be relaxed and distracted. So I'm very conscious of time. As usual, we try and pack in a huge amount on our training. I'm really grateful those of you that could stay this long, and for those that there was a couple that said, I'm really sorry, I've got to go back into numbers, and I really appreciate that is often the case. This will definitely go online so that people can watch this, and as usual, what I always say at the end of this is, let us know if there's anything else you want covered. So we try and make sure that we're covering that whole breadth of the early years curriculum and how it impacts on SEN. Obviously, we're going to be looking in the future at an SMEH one. We're going to be looking at the future around the new Ofsted framework and the guidance. So we're going to have something around that soon. But if there's anything else that anybody thinks, God, I wish they'd do something on this, please let us know. And apart from that, if you've got any questions, we know where we are as your area SENCo. Oh, the only thing I was going to do today that I haven't done is I'm just going to quickly introduce Kelly. So Kelly, wave at everybody. Kelly's our new area SENCo. So just so that you know, Kelly's joining us as our new area SENCo. Sorry, Kelly, to drop you in the spot like that, but no, I think it's quite nice on these things for people to see. So it's her first day with us today as an area SENCo, but you may know her as an ISP. So just a welcome to Kelly. Right, in that case, thank you so much for everybody coming, and I'm going to stop recording now while I remember to do that. And then hopefully, as soon as I can work out how to stop recording. Stop recording, there we go. So if anybody does want to